Assalamu alaikum. Good afternoon. It is with great pleasure to introduce our next speaker. Our next speaker is my colleague and mentor, Dr. Amr Hanbali. Dr. Hanbali is leading the ALL in AYA population program at King Faisal Specialist Hospital and Research Center in Riyadh. Dr. Hanbali is known for his dedication for education, having trained generations of fellows in the kingdom. Dr. Hanbali will give us a talk on ALL, improving results through emerging trials. The floor is yours, Dr. Hanbali.
Thank you very much. Assalamu alaikum. I know it's late and we're feeling tired, but try hopefully to go through this without giving too much data. At least it will make it, inshallah, easier. So we'll talk about ALL. This is my agenda. So the focus is going to be mainly on the Philadelphia negative ALL, looking at the current standard of care in the treatment and the use of immunotherapy in the B-cell ALL, and how the immunotherapy shifted the paradigm in the treatment of B-cell ALL. And then we're going to just go through some investigational agents that might show benefit for ALL in the future. So ALL, we know it's a clonal proliferation of immature lymphoblasts that usually displace normal hematopoiesis in the bone marrow. It accounts for around 0.2% of adult cancers. So it's mainly a disease of pediatrics. We know ALL is very prevalent in as a leukemia in children with median age at diagnosis of 17. Now, we know the outcome of ALL is age dependent. So excellent outcome in pediatrics with the cure rate exceeding 90%. But the older the patient gets, the worse the outcome. And in particular, we're having a challenge in the elderly patients with ALL. Even worse is the outcome of relapsed refractory ALL. So this is a historical data showing even with transplant, 5-year overall survival is less than 10%. I call this historical data because with the new immunotherapies and the cellular therapy, this improved dramatically. So focusing on the Philadelphia negative B-cell ALL, first, important to know the definition of AYA, adolescents and young adults, varies between different groups, but in general, the most consensus in the clinical trials is to look at ages between 15 and 39. In King Faisal Hospital, when we designed the ALL AYA protocol, we went up to age of 55, although I think between age 50 and 55, the tolerance is less, and maybe we should lower that upper age limit a little bit. Just quick comparison between pediatric and adult regimens in ALL. We know that more asparaginase and more vincristine is used in pediatrics, while more myelosuppressive agents like anthracycline and cyclophosphamide are used in the adult regimens. More CNS protection in pediatrics with more intrathecal therapies. And the other important aspect is that all phases of the adult-oriented regimens are done usually inpatient in the hospital, while only the induction is usually done in the inpatient. The rest is done as outpatient. Which is better to use adult or pediatric protocol in the AYA population? Of course, this is now validated and confirmed. Using pediatric-inspired protocols in the AYA population is superior to adult, as seen in these two studies done by Dr. Wendy Stock, and showing that in retrospective analysis, the difference is significant. And then when they did that as prospective trial, showed results, long-term outcome of above 70%, which is much better than what we used to see in the adult programs. Now, these are our results. We use the pediatric-inspired protocol in the AYA and showing a 5-year overall survival of close to 80%, which is, comparable or maybe a little bit higher than what you see in the international trials. Efforts are done to how to optimize the upfront therapy, looking at specific targets. So we know that anti-CD20 monoclonal antibodies, blinatumomab and inotuzumab, were studied in the upfront therapy of ALL. So looking at anti-CD20, we know CD20 by itself is a poor prognostic factor. So if you have expression of 20% or more, it's associated with inferior overall survival, shorter CR duration, and it's considered an independent prognostic factor. This is a GRAL 2005 phase 3 trial looking at chemotherapy with rituximab versus no rituximab and showing improvement in the event-free survival and in the cumulative incidence of relapse, while there was no significant difference in the overall survival. The other CD20 that was also looked at is ofatumumab, looked at in phase 2 trial and in combination with hyper-CVAD, and showed good results, CR rate 98% with overall survival of 68%. There is no head-to-head comparison between these two, rituximab and ofatumumab, but there is a propensity score analysis, which is a retrospective comparison, looked at these two drugs and showed that the CR rate is similar, although there is a little bit higher or trend towards higher 4-year event-free survival and overall survival with ofatumumab. But these were not statistically significant. So currently, we know that rituximab improves event-free survival and relapse rate, but not definitive overall survival. And the benefit is stronger in younger adults. MD Anderson showed that patients above 60% didn't really benefit from adding rituximab. And important also to understand that extended dosing appear to be more effective than limited dosing. Usually, the recommendation is 8 doses during the chemotherapy protocol. And as I mentioned, ofatumumab now, it's rarely used in practice, and we still need more data to adopt this medication. Blinatumomab in the upfront therapy. So we know blinatumomab is a bispecific T-cell engager and initially approved in the relapsed refractory B-cell ALL. And then the approval extended for patients with MRD positive B-cell ALL and most recently in patients with MRD negative B-cell ALL. And that's based on the E1910 clinical trial that randomized patients with MRD negative B-cell ALL to add 4 doses of blinatumomab during the chemotherapy, and that showed improvement in overall survival that was more significant in patients who are less than 55 years of age, but still even patients above 55 got the benefit, and based on that got the FDA approval for that indication. And there is always a question that, okay, adding blinatumomab can really help high-risk patients. So this is the Quest sub-study of the GRAL trial, looking at high-risk features like the MLL gene rearrangement, IKFZ1 deletion, and also MRD positivity post-induction. And actually, it showed that even with such high risk features, adding blinatumomab can still give better results than chemotherapy alone. So we know now blinatumomab is standard of care to be added to B-cell ALL regardless of the MRD status. The good news is that hopefully in the near future we're gonna get the subcutaneous blinatumomab thanks to the effort of MD Anderson and Dr. Jabbour working on it's actually in phase 2 trial now, showing high efficacy and the toxicity is manageable, and it looks like it's equivalent to the IV that we have in different trials. Inotuzumab, which is the antibody drug conjugate, which is approved in the relapsed refractory B-cell ALL and in adult and in pediatrics. It was studied in the Alliance A04 trial, which is phase 2, similar to what we see with Blina. They tried to do the same effort with inotuzumab. Unfortunately, it did not meet the primary endpoints. So there was no significant benefit. The problem is toxicity was an issue, especially with infection. And when they did the sub-analysis, they saw that maybe there is benefit in subgroups like patients who have the Philadelphia-like B-cell ALL, and also they noticed that MRD clearance is better with inotuzumab. So still, we can say that the data is not sufficient. We cannot say it's ruled out. and we cannot recommend it as a standard of care, but we're going to wait for more results. Now we know inotuzumab has done a wonderful job in older adults, okay, like in combination with mini CVD, in combination with blinatumomab, and these are the places where you can use inotuzumab in the upfront. The combination between blinatumomab and inotuzumab, as I mentioned, in the older patients, this combination produced high results, high efficacy, and in such patients you can even reduce the chemotherapy or even skip the chemotherapy and just focus on the immunotherapy. In the relapsed disease, now we know that inotuzumab and blinatumomab are the standard of care as first salvages in the relapsed refractory. There were also efforts to look at the medication called epratuzumab. If you think the concept is this is a monoclonal CD22 monoclonal antibody without having conjugate like calicheamicin that you see in the inotuzumab. So you think that will reduce the toxicity. The problem that without having the drug conjugate, this medication failed to show efficacy. So what happened now? So as we mentioned, you use pediatric inspired protocol in the AYA population, and then you add other medications or immune therapies according to the markers you have. If you have CD20, you add rituximab. Blinatumomab standard of care should be added, and usually it's around 4 cycles. And just think about the indications for allogeneic stem cell transplant, which are very limited now in the upfront therapy and, of course, the maintenance therapy. We still have some challenges that we have to look at. The MRD persistence after blinatumomab, and here we think about using the CAR T cell as a tool to eradicate this MRD before allogeneic transplant. Also using blinatumomab in the upfront therapy, it means that its role in the salvage is diminishing, and that can be a challenging issue. Inotuzumab continues to be important in the salvage more than a frontline, and remember inotuzumab has a significant toxicity associated with VOD, and transplant can be challenging, so usually avoid dual alkylator conditioning with such patients. Okay, 8 minutes. Okay, I want to move to the investigational agents. So we know that blinatumomab and inotuzumab are good medications, but still we need more efforts in the relapsed refractory patients. It's not satisfactory. We have toxicity. It's less than optimal responses. So that's why now the effort are to look at what other pathways the ALL blast are using to survive, and try to target these pathways with agents. So looking at other CD19, CD22 agents like tafasitamab, the one that it's used in lymphoma, unfortunately the CR rate that was seen in phase 2 trial was very low. Also there are other BiTEs that are looked at beside blinatumomab. So far they're not giving the results that we saw with blinatumomab, and same with the other ADCs. Non-traditional antigens like the CD123, CD127, CD25, and HER2, all these looked at with antibodies. Some are still in the preclinical phase, some is phase 1 and phase 2. So these are things that we might hear about in the future. How about the checkpoint inhibitor PD-1? So pembrolizumab was looked at in phase 2 in ALL. Unfortunately, this study was terminated due to limited efficacy. Menin inhibitor, so we heard about menin inhibitor in AML. Most of the effort is done in AML, but ALL now is going higher, especially for patients with MLL gene rearrangement or KMT2A. And so far it's promising. We still need more studies to validate that. Many of these agents are still in phase 1 trial, but I think this will be an area where such medications will be needed, because we know that the KMT2A is one of the worst prognostic factors in ALL. We know also venetoclax, the BCL2 inhibitor, studied. There is good studies in ALL. Initially was studied with navitoclax and the low-intensity chemotherapy, and this is done in the relapsed refractory both B-cell and T-cell ALL. Also, this study was discontinued because of high toxicity. So there was 20% fatal toxicities. Venetoclax combined with the mini hyper CVD showing good results. Also, we have good outcome with the relapsed refractory Philadelphia positive ALL combined with the TKIs, like these two studies. This is from China. And so there are a lot of studies looking at venetoclax in the upfront, in the relapsed refractory. We know T-cell and B-cell can benefit from such medication, so we are awaiting for more results in that area. HDAC inhibitors also looked at in B-cell ALL. Their role remain investigational. The outcomes are not as impressive. mTOR inhibitor, and the rationale, you can think about patients who are steroid resistant might really benefit from such medications. So multiple medications were studied, but all had showed also limited clinical activity as monotherapies, and still more data is needed. The RAS pathway also looked at. Different medications were used. Same thing, have showed just limited efficacy. We have the CDK4/6 inhibitor, which also studied in phase 1, showed poor durability of response, and overall survival was short. Proteasome inhibitors, medications we use in myeloma. We know that bortezomib showed excellent result with T-cell, but how about the B-cell? Looked at different studies. Still also we don't have strong data to support their use. Hypomethylating agents also have been studied in ALL. Same thing, no substantial activity. So in conclusion, if we look at all these medications and all these pathways, that maybe the two areas that are promising are using the menin inhibitors and venetoclax. And hopefully we're going to see more and more of these data that can support treatment of the relapsed refractory ALL. I have 3 minutes. Just quickly about the CAR T-cell. I'm not going to talk about CAR T-cell, but I'm going to tell you where are we heading. So these are the 3 agents that are FDA approved. One is for the AYA population, which is the T-cell, while the Bruxa-cell and Obe-cell approved for adult ALL. The future is, all the studies now, they're trying to think what's the optimal time to use the CAR T-cell. And especially now we're thinking about using blinatumomab, inotuzumab in the upfront, so the CAR T-cell should be thought about maybe in the first salvage, not as we do it now that we wait as, like second or beyond salvage to use it. Also, like you see, this table showing you how many structures that were published, and they're all going to be, you're going to keep hearing about FDA approvals. So with having too many, you start thinking how to use them and how to sequence them. So that's going to be a challenge. Then also the allogeneic CAR T-cell is still under investigation, and we need to see what's the role in ALL. CAR T-cell and T-cell ALL, we're awaiting for that. T-cell is poor. Doesn't have as much as B-cell in therapy. So at least this CAR T-cell hopefully will help. The Y2TB323, this is the rapid manufacturing. We know that manufacturing takes time, around 2 weeks. This is like less than two days of manufacturing. So these are some of the things that are coming. And then we talk about the dual CAR constructs, so instead of CD19, there's CD19, CD22, so it helps with the antigen escape, with the resistance, and hopefully those will be approved also soon. 1 minute. Optimal sequencing of therapies remain unclear. So blinatumomab and inotuzumab, we're still thinking about them. Of course, blinatumomab now approved in the first line, waiting for ENO. Allogeneic stem cell transplant, very limited indications. Okay, and it shouldn't be done routinely. CAR T-cell therapy, we're still waiting to understand more about the sequence of using CAR T cell after the immune therapies. And with that, I'll finish. Thank you very much.